Hi, my name is Corina Fierro. I'm going to talk about Letermovir prophylaxis for Cytomegalovirus in hematopoietic cell transplantation. Definition: Cytomegalovirus disease that results from CMV replication through reactivation or new infection is a serious, potentially life-threatening condition in immunocompromised patients. This is especially true for recipients of allogeneic hematopoietic cell transplants.
The ideal approach would be to be able to prevent CMV reactivation, even not to make sure that we don't get any CMV reactivation, and to use a drug prophylactically. Of course, there are limitations. Like we want to make sure that those drugs are safe, they're non-toxic, they don't have significant interactions with medications that are being used for the transplant, such as calcineurin inhibitors, and don't cause the kind of cytopenias that you described. And of course, they're effective. There has been one drug recently approved, Letermovir, and I know you've had some experience with that. And could you describe Letermovir, its mechanism of action, and how it's been used?
Yeah, it's been an exciting time in the field of CMV and transplant. The Letermovir approval culminates a 10-year quest to find an agent that is suitable for prevention in the stem cell transplants. We know that in the solid organ transplants, valganciclovir is used routinely for CMV prevention. However, valganciclovir is not an option for stem cell transplants due to cytopenia. Letermovir is a very potent CMV-specific antiviral that has a novel mechanism of action. It inhibits the terminase. It's an enzyme of CMV that cuts the DNA at the appropriate place as the CMV DNA is produced. And it stops CMV packaging and eventually the completion of the CMV particles. Recently, a phase 3 trial was concluded with very strong results, showing that Letermovir was very effective in preventing a CMV infection when given for 14 weeks after transplant.
I know that patients can still be at risk for CMV after those 14 weeks. It's still important to monitor them after completion of Letermovir for patients who might be getting Letermovir.
So a very important manuscript with first author Dr. Marty from your institution that showed that Letermovir was extremely effective in the first 14 weeks that was given. The patients were followed subsequently through 24 weeks after transplant, so about 6 months after transplant. And we saw that a number of patients that had not developed CMV infection in the first 14 weeks, they went on to develop infection in the last part, from 3 months to 6 months after transplant. So all of these patients are routinely monitored, and so they start preemptive therapy later on.
So CMV infection, it's not just viremia that we're trying to prevent. We're obviously trying to prevent CMV disease, and I don't think in this particular manuscript there was a difference in CMV disease, but as I recall, there was a difference in mortality after transplant. Could you talk about that?
Yes, so CMV disease is pretty well prevented nowadays, and we have seen that in previous randomized trial, and in this trial that CMV disease at 6 months was less than 2% in the Letermovir arm and in the placebo arm, showing that preemptive therapy is very effective in preventing CMV disease. Now, always in clinical trials, patients are monitored extremely well. So in the real world, perhaps the CMV disease rate at 6 months may be a little higher than 2%. But again, the rates are low in general. What's very exciting about the Letermovir trial is that there was a difference in mortality at 24 weeks and a trend for lower mortality with Letermovir at 48 weeks. So this is the first time in a randomized control setting that we see that an agent for prevention of CMV infection has an impact on mortality.
Application in medicine. The study fulfilled its main efficacy variable, showing that a significantly lower number of patients with undetectable levels of cmV-DNA at the start of treatment of the clinically significant study developed CMV infection throughout the week. In the study, Letermovir prophylaxis is associated with lower mortality from any cause until week 24. These results show that the Letermovir prophylaxis commences after HSCT and continues until day 100 post-transplant, significantly reduced CMV infection requiring preventive antiviral therapy through 24 weeks post-transplant.
I think what we've done is talked about our general approach, and what I'm learning from you today is that it would be really great to have some prophylactic measures. But let me make sure I understand then. You don't need to prophylax patients who have CMV negative recipients. Is that right?
Correct. If they're CMV negative into negative.
Both negative.
Yes. Negative into negative, yes.
But
that's actually
one of them.
not
Very
that
low risk.
common.
Not common anymore.
Yes.
Okay. Okay, so let's move on then. Currently none of these agents are
No, I mean,
available
the only thing I would comment
prophylaxis.
on is that particularly in the cord blood, the use of valacyclovir at high dose is thought perhaps to have some
There's some
effect.
data. If they can tolerate the high dose, actually,
which is it's an enormous dose. It's,
So go 2 grams 3 times a day, and
2 grams 3 times a day, Harry.
Sometimes not well tolerated. But there's some data showing maybe it protects against CMV.
Yeah.
Okay, but fortunately, Dr. Chamali, you have done some further work in this area with a new antiviral agent that may be potentially used in the future in prophylaxis. Do you want to tell us more about that?
Yeah, actually, so we conducted a phase 2 trial on Letermovir versus placebo. An allogenic transplant recipient tried to prevent CMV from reactivation. We enrolled around 131 patients, and it was dose escalation study as well versus placebo, and it met the primary endpoint and prevented around 50% of CMV reactivation when you compare to placebo, and the highest dose, which was 240 milligram once a day, and they took it from anytime before engraftment up to. Actually, from time of engraftment up to day 100. So, say week 12 to week 14, they've been on the study drug, and it worked very nicely. We didn't see any much of a safety signal from the drug. It was all SAEs or AEs were comparable to the placebo. There was no evidence of myelotoxicity or nephrotoxicity that we worry about in this patient population, or even liver toxicity based on this phase 2 trial.
So randomized phase 2.
It was randomized placebo-controlled, yes. And the phase 2 tried, this was back in 2014. And after that, because of this encouraging results and the positive result, we went ahead and we moved forward with the phase 3 trial. More than 500 patients, I think it was around 540, if I remember well, and enrollment was completed. We have data. It's publicly available now through a press release where it met the primary endpoint at week 24. What's interesting, what we found is that you treat patients, or you put them on prophylaxis with Letermovir versus placebo till week 14, and after that you stop the study drug, and you continue monitoring them to week 24. And see how many will have reactivation over that time period. And it was much less on the Letermovir than on the placebo arm. So it met the primary endpoint, and it was a positive trial. But still, it's under analysis, and hopefully you will hear more about it.
In the phase 2, it was about a 70% overall reduction in the risk of reactivation. What is that holding in this?
It's around between 50 and 70, I would say. It depends on the dose that you look at, and also what we did in the phase 2, if you remove actually all, so they had some patients who had early reactivation and they were enrolled in the, in the study. And if you remove this patient who had already reactivated before you started the study drug, actually it was 100% effective, the 240 milligram.
And how early had they reactivated?
It was pretty early, actually. It's what before even, it's around day 20, I would say.
I was going to say, I'm not sure we even begin screening until.
Right. But now these days, actually, the practice is changing a little bit because of the sensitive PCR. So we start screening early on, and we start seeing some reactivation even before engraftment.
So, and when you stop the study drug, I'm sure you looked at what the reactivation rate was like after that, right?
Yeah, it was also much less on the Letermovir
versus the placebo.
It was still week 24. Yes.
Oh, that's interesting. So, okay, but it brings up a drug approval question that I'm going to have because, to me, what I've heard so far in terms of treating active CMV is you don't even know when to start your treatment. The drugs you have are toxic. But I think I heard you say very few people are dying a CMV
well, we are
anymore.
treating our approach, because we remember all those patients dying. We, at my institution, leap on a positive result, and they're hammered with the toxic treatment.
Absolutely, and this is the problem with the same viremia. It's not only about, although any viremia, as I mentioned earlier, it put patient at disadvantage for survival.
The sheer cost of this, when we have to add valganciclovir or ganciclovir to these patients, transfusion goes up. I mean, everything just goes haywire.
I know you're preaching to the choir. I understand, but at the end of the day, okay, how are we going to get this? It sounds like a drug that patients need, that clinicians need for their patients, based on its toxicity profile and efficacy in terms of decreasing reactivation. And we understand when reactivation occurs how sick these people get, all of the cost utilizations, but you didn't quite yet tell me that we know that survival is worse.
Well, so that comes down to the diagnostic test.
Okay, but let me ask, is the endpoint going to be survival or is it going to be reactivation?
So this trial, it was mainly reactivation.
That one for the randomized phase 2.
But
in phase 3?
Even phase 3. Oh. Actually, it was mainly, failure of prophylaxis or the occurrence of clinically significant CMV viremia necessitating antiviral therapy.
Well, that's good.
So it wasn't survival, but secondary endpoint is survival. So,
but I mean, a validated assay, a
Yeah.
molecular assay, something we've longed for in our field.
Oh, that's why we can't do it in AML.
That's why you can't wrap your mind around this.
That's right. I understand you actually have a
disease.
Validated assay.
Yes.
Okay. Yeah. Well, that's good for patients because that's the point I was trying to get to.
You're preventing so many viremia and so many toxic drugs can be given to patient. If you have a good, safe oral drug that you can give to your patient during their high-risk period.
Pros and cons. Letermovir, previously known as AIC-246, is a new highly potent anti-CMV agent with a novel mechanism of action targeting the viral terminase subunit. As such, Letermovir also provides a potential new treatment option for patients infected with CMV strains that are resistant to approved antiviral drugs.
We are presenting a randomized placebo-controlled trial of a new antiviral drug against Cytomegalovirus called Letermovir. These are the results of the study that was multinational, going on in the US, North America, and in Europe, with EBMT as a very strong supporting actor in the European part of the study. The CMV is a virus causing significant morbidity and also additional deaths in stem cell transplant, and this study was aimed to prevent what's called significant CMV infection. It was approximately 500 patients randomized, and the results of the study show not only that significant CMV infection was significantly reduced, meaning that the study met its primary endpoint, but it also showed that at 48 weeks after transplant, namely almost a year, the all-cause mortality and the non-transplant, non-relapse mortality actually was decreased in the patients that got Letermovir. I also should say that it was well tolerated. So there were some side effects, of course, as with all drugs, but no very severe side effects. Well, the next steps, of course, is that the drug hopefully will be approved. It's a new drug, so it's not licensed for use anywhere in the world at this moment. Basically, there were very limited side effects, and the side effects were mostly from taking an oral drug. So it was some gastrointestinal side effects, as with almost all drugs, but very low difference to the placebo, and no renal toxicity, which is important in stem cell transplants, and even more important, no bone marrow toxicity. The data is just coming out now, and I would expect, if the authorities think this is a good drug and license it for use, I think it will be included in the algorithm, meaning that we would use a prophylactic drug against CMV in at least significant proportion of allogeneic stem cell transplant patients.
Issued apply in Ecuador. The medicine is available in the form of oral administration tablets and IV solution vials for intravenous infusion. Post-processation are available in doses of 240 and 480 milligrams. The recommended dose is 480 per day. Conclusion. Letermovir, as compared with placebo, was effective in reducing the incidence of CMV infection on recipient of allogeneic hematopoietic cell transplant. The highest dose had the greatest anti-CMV activity, with an acceptable safety profile. Thank you.